The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day everyone, so welcome back to Top Notch, and today we're going to be discussing about yung exam discussion ninyo for midterms. The midterm exam was actually authored by Dr. Jessica Castillo, so I was just assigned to do the explanations for all of the questions and the answers, and we only have 1 hour to discuss this, so bilisan na natin, okay? So number 1, a 35-year-old male. So most likely nabasa nyo na rin naman, and medyo familiar na kayo dun sa question stem. So medyo mag-jump lang ako dun sa mga key phrases na nandun sa question stem, okay? So itong 35-year-old male na to is obese, and I guess the only question here is which among the following nutrients should be decreased in his diet to lower his CVD risk. So the correct answer is saturated fats. So you might get confused dito. Pwedeng ang isagot niyo is carbohydrates, but the answer is saturated fats. Well, obviously because ito yung diniscuss sa Lippincott na type of cholesterol that is associated with an increased risk for coronary heart disease. Okay? And how about yung iba? Okay, let's start with MUFA. MUFA is monounsaturated fatty acids. It is actually the opposite of LDL cholesterol because the consumption of MUFA or monounsaturated fatty acids, they lower both total plasma cholesterol and LDL cholesterol. Okay, it's the opposite of LDL cholesterol. And how about yung carbohydrates? Di ba sinasabi nila pag marami ka kinakain na rice, is tataba ka and it will increase your CVD risk. But you have to remember that carbohydrates are not inherently fattening. It means that if you eat carbohydrates at a moderate amount, no? I mean, kunwari hindi ka nagbe-binge on rice, like 5 rice in one meal, then you're less likely to get increase na CVD risk. Kasi carbohydrates on its own, intrinsically, hindi fattening ang carbohydrates. Okay? But yung saturated fats, they are inherently pwedeng makapagpa-increase ng risk ng coronary heart disease. And it's the same thing with proteins. Okay? Okay, so the way na the PLE works, you have to remember, aside from knowing kung ano yung which of the following nutrients can increase your CVD risk, you also have to know anong saturated fats specifically. Kasi the way the PLE works is hindi tinatanong specific, kumaga hindi mauulit yung same question sa PLE. Ang pwedeng maulit is yung topic surrounding that or the concepts surrounding that topic. So for example, dito sa question na to, alin ang pwedeng mag-increase, ano yung pwedeng pag decrease mo is it will also lower your CVD risk. The answer is saturated fats. So sa PLE, it's less likely na maulit itong same question na to. So dapat alam ninyo kung anong klaseng saturated fatty acids yung pwedeng makapagpa-increase ng CVD risk. So for example, which is why I included dito, so this is from Lippincott, kung ano specific na saturated fatty acids. And those are yung saturated fatty acids na may carbon chain lengths of 14 and carbon chain length of 16, which are myristic acid and palmitic acid, respectively. But you have to know na yung 18 carbon chain length na saturated fatty acid has little effect on blood cholesterol. Hindi tulad ni 14 and ni 18 na nakakapagpa-increase ng plasma cholesterol. Yung 18, okay, yung 18 which is stearic acid, it has little effect on blood cholesterol. Okay? And this stearic acid is found in chocolates. Okay, which of the following statements accurately describes the composition of fetal hemoglobin? The correct answer is letter B. Okay, so alam na ninyo ito. I'll just leave this to you para basahin. But let's go to this one, to this slide. So there are different types of hemoglobin. So according to first aid, meron tayong fetal hemoglobin, meron tayong adult hemoglobin, and itong mga hemoglobin na to, makita nyo to sa lipin coat or dun sa inyong handouts. And it could be confusing. Okay? I understand that. But you have to notice na lahat ng hemoglobin is, hindi naman lahat, pero yung mga important na hemoglobin is meron lahat silang alpha. Which is why very useful itong mnemonic na to, which is you can find sa first aid. Alpha always, meaning si fetal hemoglobin is may alpha globin chain, and si adult hemoglobin meron ding alpha globin chain. Nagkakaiba sila dun sa second na globin chain. Si fetal hemoglobin, for example, is alpha gamma. Okay? And then si adult hemoglobin is alpha beta. Which is why dito sa mnemonic na to, sinasabi niya alpha always, meaning laging may alpha, but the gamma goes away from the fetal hemoglobin to become adult hemoglobin, and which means yung gamma is mawawala and then mapapalitan siya ng beta hemoglobin. Kaya siya tinawag na becomes beta. Okay. So the way you can remember this, for me, it could be confusing lalo na if nandun ako sa actual exam and medyo pressured na ako, hindi ko maalala to. So which is why very useful ang ang mnemonics. So the way I would remember this is di ba ang baby nag-aano siya, yung kanyang baby talk is gugu gaga. So the way I remember this is gamma tsaka alpha, gugu gaga, para sa fetal hemoglobin. So, and pag naalala na ninyo yung sa fetal hemoglobin is gugu gaga or gamma globin and alpha globin, sa adult hemoglobin is maalala na ninyo na alpha and beta yung globin chains sa adult hemoglobin. Okay? So I'll just leave this to you para memorizein. Okay? These are the less important na mga hemoglobins, but ito yung more important. But I'm not saying na hindi nyo rin dapat malaman to, okay? Number 3, all of the following are derivatives of phenylalanine except the correct answer is D. Okay? Why? Because ang niacin is a derivative of tryptophan and not phenylalanine. So the way you can remember yung mga derivatives ng phenylalanine is by remembering the mnemonic PTLDNE, or para true love does not exist. Okay? So this is also a figure that you para mas ma-appreciate ninyo na ang niacin, which is also vitamin B3, it's a derivative of tryptophan. Okay? And aside from PTLDNE na mga derivatives ng phenylalanine, we also you can also say na thyroxine and T3 are derivatives of tyrosine, which is also a derivative of phenylalanine. Okay? So aside from those dimensions, pwede ring T4, T3, and we also have melanin, which is from DOPA, which is also a derivative of phenylalanine. Okay? Number 4, the basis for the diagnostic test of HbA1c is letter A, glycation. Okay? So there's a difference between glycation and glycosylation, and it could be confusing again. So the way I would remember this is, as you can see, ang glycosylation is the enzymatic attachment. Ang glycation is the non-enzymatic attachment. So the way I would remember this is, ang enzymatic is may Y. And pag ang tanong is kung sino yung may Y, pag ang tanong is kung sino yung may Y, kita mo tong glycosylation, dalawa yung Y niya. Okay? Glycosylation, dalawang Y, siya yung enzymatic. Tapos, ang glycation is isa lang ang Y, kaya siya tinawag na non-enzymatic. Okay? Ibig sabihin, wala na siyang Y kasi non-enzymatic. I hope that makes sense. Non-enzymatic, isa lang yung Y, glycation. Enzymatic, dalawa yung Y. Okay? So, it's different. Okay? You have to be... so, sa PLE kasi, medyo... majority ng mga questions sa PLE is recall-based, one-step questions. So, yung mga ganito kasimpleng questions, these kinds of questions na parang they look deceivingly simple, tinatanong talaga sila. Okay? Number 5, ribose, the building block of RNA, is produced from which metabolic pathway? The correct answer is letter C. Ang tanong is ribose. Okay? So, less likely na ang sagot is A or B kasi gluco, may gluco sila na prefix. So, less likely hindi yan ang answer kasi ang tinatanong is ribose. Saan sila galing na pathway? So, correct answer is letter C, PPP or HMP, hexose monophosphate shunt. And there are two reactions sa PPP. We have the oxidative pathway and the non-oxidative pathway. It starts with a glucose 6-phosphate becoming 6-phosphogluconate, becoming ribulose 5-phosphate, and then becoming ribose 5-phosphate. So this is the PPP. Okay? And yung kanyang end product, which is ribose 5-phosphate, siya na yung papasok sa nucleotide synthesis. Which is why dinikit ko yung image nitong PPP na to, which is from first aid. Dinikit ko to dito sa image below, which is the purine de novo synthesis pathway. Kasi, after magkaroon ng ribose 5-phosphate, which is from the PPP, yung ribose 5-phosphate becomes the starting point ng de novo purine synthesis. Kasi nakita nyo to, ribose 5-phosphate, which will eventually become mga nucleic acids natin, GMP and AMP. Okay? Okay, so bakit let me just reiterate it. Bakit hindi yung de novo purine synthesis yung answer? Kasi ang tanong dito is saan galing yung ribose? Hindi tinanong kung saan papunta yung ribose. Okay? Hindi tinanong kung saan ginagamit si ribose. Ang tanong is saan siya produced, which is why the answer is pentose phosphate pathway. Kasi ribose is produced from the pentose phosphate pathway and is used in the purine de novo synthesis pathway. Number 6, alin daw, actually itong tanong na to, ang tinatanong lang niya is kung alam mo talaga kung ano ibig sabihin ng CAH, which is congenital adrenal hyperplasia. Kasi ako personally, nako-confuse din ako nung una na kung congenital adrenal hypoplasia ba siya or hyperplasia. So the correct answer is congenital adrenal hyperplasia. Kasi yung isa, so tandaan niyo congenital adrenal hyperplasia, ang kasama niya is congenital hypothyroidism. Okay? And you also have to remember the rest of the diseases na screened in the newborn screening natin. Okay? Next question, ano yung most common enzyme deficiency dun sa question before, yung CAH? The correct answer is 21-hydroxylase. It's also mentioned sa first aid na the most common enzyme deficiency is kasi may iba't ibang pwedeng maging enzyme deficiency sa CAH eh. Pero the most common one is the deficiency with 21-hydroxylase. So, saan yung 21-hydroxylase? Ito siya, yung letter B. Okay? This green box or green rectangle na to. Diyan may deficiency. Yan the most common cause ng CAH. Okay. So, as sinasabi dito, ang presentation daw ng 21-hydroxylase deficiency is salt wasting and childhood precocious puberty. So you only have to look at this figure to know why. Okay? Kasi as you can see, so ito yung pathway. So we have 3 columns. Column 1, column 2, and column 3. And dito sa column 1, dito na po-produce si aldosterone. Dito naman sa column 2 na po-produce si cortisol. And dito yung mga sex steroids which are testosterone. Okay? Now, pag nagkaroon ng deficiency ng 21-hydroxylase, yung progesterone, hindi na siya magiging aldosterone. Okay? Yung progesterone, hindi na siya magiging aldosterone. Yung 17-hydroxyprogesterone, hindi na rin magiging cortisol. Okay? So what happened, dahil dito sa blockage na to, dahil sa deficiency ng 21-hydroxylase, may ipon yung substrate na progesterone and 17-hydroxyprogesterone and they will get shunted from dito sa column 1 and sa column 2, itong dalawang substrates na to will become shunted dito sa third column, magiging silang androstenedione, meaning dadami yung androstenedione kasi hindi makababa si progesterone and si 17-OHP, hydroxyprogesterone, magiging silang androstenedione, magiging dadami yung testosterone. So dahil maraming testosterone, that's the reason why may precocious puberty, may virilization, sa kung XX, kung female yung patient na may CAH. And the reason kung bakit sila may salt wasting is mababa yung kanilang aldosterone kasi nga may deficiency ng 21-hydroxylase. Okay? So, mababa, kasi di ba the function of aldosterone is to reabsorb sodium and to secrete potassium. So, kung hindi sila kung walang aldosterone, walang magre-reabsorb ng sodium and wala rin magre-reabsorb ng, and where sodium goes, water follows. So, magkakaroon din sila ng, so mag-iihi lang din sila ng iihi dahil hindi nare-reabsorb yung sodium. Okay? That's the reason that kung hindi nare-reabsorb yung sodium, that's the reason kung bakit sila may salt wasting. Okay, number 8. Which of the following amino acids can be synthesized in the body? The correct answer is asparagine. So, pag ang tanong is which can be synthesized in the body, ang tinatanong is kung ano yung dapat mong kunin from the diet, which means ang tinatanong is ano yung essential amino acids. So, the only thing na hindi essential dito is letter D, asparagine. And the essential amino acids can be remembered by using this mnemonic na Private Tim Hall. As you can see, may valine, may leucine, and may phenylalanine. Pero hiwala ang asparagine. Okay? So, ang pwede nyong, isang point of confusion here is yung A. Kasi yung A pwedeng asparagine, pwedeng arginine. So, which is why itong Private Tim Hall always argues, meaning yung A is always arginine, and yung T is never tyrosine. Okay? Kasi yung T is threonine and tryptophan, but never tyrosine. Okay. Okay, next question. Which of the following statements accurately describes the process of oxidation and reduction in a chemical reaction? The correct answer is letter B, no? So okay, nauuso na rin sa Biochem, sa PLE, itong mga ganitong basic organic chemistry na questions. So you also have to remember these. And the way that you can remember it is using the mnemonic oil rig. Oxidation is losing electrons, and reduction is gaining electrons. Okay? Oxidation is losing electrons, reduction is gaining electrons. And by the name itself, oxidation, gain of oxygen. So yes, loss of electrons on oxidation, but there's gain of oxygen sa oxidation kasi oxidation siya. Okay, by the name itself. It will gain oxygen, and and in contrast, ang reduction is loss of oxygen. Okay. Number 10, which of the following compounds cause inhibition of complex 5 of the electron transport chain? The correct answer is letter C, oligomycin. So, it could be confusing again, yung mga maraming names ng iba't ibang toxins that can inhibit the different complexes of the electron transport chain. So, may mga iba akong mnemonics for this. For example, complex 1 is roten 1. Okay, complex 1, roten 1. Imbis na rotenon ang pronunciation, roten 1. And then, complex 3, in-inhibit siya ng anthromycin. So, ini-imagine ko may number 3 dito, anthromycin. Okay, so that's actually from first aid. And ang complex 4, tandaan ninyo yung suffix na IDES, IDES. Okay? It's a 4-letter suffix. Kasi, ang mga nag-i-inhibit sa complex 4 ay meron suffix na ide. Saya, nide, hydrogen sulfide, carbon monoxide. Okay, sila yung mga nag-i-inhibit sa complex 4. And so sila yung mga ides. IDES, 4-letter suffix, sila yung nag-i-inhibit sa complex 4. Oligomycin, the way I would remember this, it's quite of a long shot, but ini-imagine ko, di ba may unligo is may ligo sardines? Okay, so unligo sardines is maliban sa ligo sardines, meron ding 555 na sardines. So, ligo, oligo, complex 5, 555. So, pares silang sardines, brand ng sardines. So, ganun ko siya nire-remember, no? Number 11, muscle tissue cannot regenerate glucose in fasting because it lacks glucose 6-phosphatase activity. Okay, so kung hindi nagko-contribute ang muscle in generating glucose during fasting, para saan niya ginagamit yung muscle glycogen? So, sabi sa Harper's, muscle glycogen cannot contribute directly to plasma glucose kasi ginagamit ng muscle, yung muscle glycogen, to provide a source of glucose 6-phosphate in the metabolism of the muscle itself. Okay? So, ginagamit niya for its own use, yung muscle glycogen. Okay? And the reason why hindi siya nakaka-contribute generation of glucose in fasting is wala siyang glucose 6-phosphatase activity. Eliza, a pure vegan, is probably suffering from a deficiency of what vitamin? The correct answer is letter B, vitamin B12, cobalamin. If it were a deficiency in retinol or vitamin A, it would be night blindness, ophthalmia, and scaly skin. Pyridoxine is B6, so B6 deficiency, and B2 is riboflavin deficiency. So, tandaan niyo ang B2, ang flavin deficiency is riboflavin deficiency is associated with magenta tongue and corneal revascularization. Okay? Or corneal vascularization. Mababasa niyo lang tong phrase na to dito sa riboflavin deficiency. No, I haven't read na nabasa ko siya sa ibang vitamin deficiency. Dito nyo lang siya mababasa, corneal revascularization. And the reason why ang isang patient na pure vegan is maybe can suffer from cobalamin deficiency is because cobalamin or vitamin B12 is only synthesized by bacteria sa intestinal microbiota ng animals. So which is why ang cobalamin is only obtained from animal sources. Okay? So kung pure vegan yung patient, wala siyang animal sources, wala siyang source of vitamin B12. Okay? Based on the 2018 ENNS, the most vulnerable group affected by malnutrition is letter B, children under 5 years of age. So, I understand na merong mas recent na ENNS sa 28. Pero ang tinanong ni Dr. Castillo dito is 2018. Maybe ito yung tinanong sa PLE noong March 2023. Even if there's already, I think there's a 2021 or 2022 ENNS, no? So, 2018 yung tinanong siguro, kaya itong ginawa ni Dr. Castillo. So the most vulnerable group is children under 5 years of age, and meron ding mean weight, mean height of children na nakasulat doon na kailangan nyo maalala kasi baka itanong ulit. Most crucial time to meet the nutritional needs is the first 1,000 days from birth. Okay, ito another basic biology, kanina is basic organic chemistry, dito naman is basic biology question. The correct flow genetic information is replication, transcription, and translation. Okay, so alam na ninyo to. Effect of non-competitive enzyme inhibitors to the maximum velocity and Michaelis constant. The correct answer is letter D. So I don't have a mnemonic for this, but it could be it could be difficult na maalala siya during the stress of the exam. So the way I would do this kung ako to, para maalala ko siya, di ko siya malimutan, is I would write down this exact same table. Okay? So, magsusulat ako ng competitive and then non-competitive. And then, para hindi ako ma-confuse kung ano yung ilalagay kong words dun sa each of the boxes na ginawa ko, is, tingnan nyo to. Itong competitive is, di ba, sabi dito, pag competitive inhibition, yung Km would increase and the Vmax would wala siyang change. Non-competitive is, ang Vmax ay decreased, pero ang Km is no change. So, parang hindi ako ma-confuse. Yung competitive, gagawin kong K, competitive, letter K ito, and then Km, competitive, Km, and then competitive. Okay? So, maglalagay ako dito ng increased. Okay? Para maalala ko sa sarili ko na Km is increased, Km is increased, which means, kung Km increased, yung Vmax is no change. Okay? And it's medyo opposite siya ng non-competitive kasi kung ang Km is increased sa competitive, sa non-competitive ang Km is no change. Okay? And ang Vmax is decreased. Okay? So yun, that's the way I would write it. Okay? Number 16, 10-year-old male may hexagonal crystals sa urine microscopy. Yung all of the following amino acids are excreted owing to a defect in the transporter except leucine. Okay? So this is a case, yung hexagonal crystals yan, mababasa nyo lang yan sa cystinuria. Okay? And apat yung hindi niya nare-reabsorb. Okay? So there's a hereditary defect in the renal PCT, proximal convoluted tubule, that prevents the reabsorption of CoLA. Sabihin, hindi niya nare-reabsorb yung CoLA. CoLA stands for cysteine, ornithine, lysine, and arginine. And So, hindi leucine, hindi included si leucine doon. So, the way I would remember this is lysine, lysine, may Y. Cystinuria is may Y din. Okay? Si leucine is walang Y. Okay? Which is why hindi dapat kayo ma-confuse kung ano yung what L stands for. L stands for lysine and not leucine kasi L-lysine, cystinuria siya. Okay, so pareho may Y. Ornithine and arginine. Okay. Number 17, the net ATP yield in the TCA cycle is 10. So alam na ninyo to. We'll not go into the details of this. But just briefly, I'll just show you kung saan galing yung 10 na yon. So we have 2.5 galing sa NADH. Kasi tatlo yung NADH natin. So ito yung first NADH, ito yung pangalawang NADH, yung pangatlong NADH is this one. And then may isa tayong FADH2, which is equivalent to 1.5 ATP. Ito yung first na FADH. So number 18, what type of linkage is hydrolyzed by glucosidase, partially with the branching enzyme or glycogenolysis? Ang question dito is, so medyo confusing siya, no? Ang question dito is, what type of linkage is hydrolyzed by a glucosidase, or what type of linkage is hydrolyzed by a debranching enzyme na glucosidase sa glycogenolysis? Okay? So before we, so the correct answer is alpha-1,6 glycosidase linkage. Siya yung linkage na hinahydrolyze ng isang debranching enzyme na glucosidase sa glycogenolysis. Okay? So before we, before you can be able to answer yung question na yon, is you have to know first kung ano yung mga bonds na nasa glycogen. Okay, so we have yung linear na glycogen and we have yung branch nung linear na glycogen, we also have branches ng glycogen. Okay, ito yon. And kung ito, dun sa linear na linkages niya, we have alpha-1,4 bonds. And dun sa branches, for example, ito yung isang branch, ang bonds dyan is alpha-1,6. Okay? Now, meron tayong dalawang klase ng debranching enzyme. Okay? 4-alpha-D glucanotransferase and alpha-1,6 glucosidase. Okay, yun yung dalawang debranching enzyme. So, by elimination, wala namang choice na 4-alpha-D glucanotransferase. So, the answer dito is itong letter B, which is alpha-1,6 glycosidic linkage. Kasi yung enzyme na pangalawa na na-discuss natin, yung pangalawang debranching enzyme, ang pangalan niya is alpha-1,6 glucosidase. So, by the name itself, ang ina-hydrolyze ng alpha-1,6 glucosidase is the alpha-1,6 glycosidic linkage. Okay? So, saan nag-a-act itong alpha-1,6 glucosidase na to? Dito siya nag-a-act. Okay, so kung ito nga yung linear na glycogen, alpha-1,4 ang linkages nito, from this glucose to this glucose na nag-branch siya, may alpha-1,6 glycosidic linkage dyan. Okay, alpha-1,6 glycosidic linkage, yung answer dito. And hina-hydrolyze siya na alpha-1,6 glucosidase. Okay? Which is why itong si number 7 ay nandito. Okay? Kasi with the use of, so kung ito is alpha-1,6 glycosidic linkage, with the use of alpha-1,6 glucosidase, ika-cut niya tong branch na to, itong link na to, para magkaroon ng free glucose. Okay. Kasi it is glucose eh. In order to free this glucose from the linear na glycogen, in order to free this glucose, you need alpha-1,6 glucosidase to hydrolyze the alpha-1,6 glycosidic linkage para magkaroon ka ng free glucose. Okay. Okay, number 19, red-orange sand-like material on her diaper, aggressive lately and hurts herself. What is her primary consideration? The correct answer is letter B, Lesch-Nyhan syndrome. Okay, so this is the same figure na I showed you about yung purine de novo synthesis, and it also shows here kung ano yung mga yung pag nagkaroon ng enzyme deficiency is ano yung mga conditions na pwedeng mag-result yung enzyme deficiencies na yon. So for example, dito sa purine de novo synthesis nito, pwedeng magkaroon ng deficiency ng HGPRT, which stands for a hypoxanthine guanine phosphoribosyl transferase. If there's a deficiency there, magkakaroon ng Lesch-Nyhan syndrome, which is yung patient na to. Pag aggressive lately and hurts herself, Lesch-Nyhan lang yun. Okay, ADA deficiency does not present with that, lalo na yung SLE, lalo na yung juvenile onset gout. ADA deficiency Ano ba yung ADA deficiency? ADA deficiency is nangyayari yun sa SCID or Severe Combined Immunodeficiency Syndrome. Okay? ADA deficiency yun. Pero pag ang deficiency is HGPRT, Lesch-Nyhan syndrome yun. Okay? So this is the same figure that I showed you kanina kung saan pumupunta yung ribose 5-phosphate after being synthesized in the PPP or the pentose phosphate pathway. Okay? The glycosaminoglycan heparan sulfate is composed of what sugars? The correct answer is glucosamine and glucuronic acid. So ito yon. So it maintains the charge selectiveness of the renal glomerulus. So anong kahalagahan ng heparan sulfate? So as I said kanina, aside from knowing kung ano yung sugar units ng GAG or ng glycosaminoglycan na heparan sulfate, aside from knowing kung ano yung kanyang sugar units, you should also know kung ano yung function niya. So, ang heparan sulfate is makikita mo siya sa basement membrane. It maintains the charge selectiveness of the renal glomerulus. Kasi, normally, may heparan sulfate sa basement membrane. Okay? And it's negatively charged. So, what happens is, dahil ang albumin is negatively charged as well, and yung heparan sulfate is na nasa basement membrane is also negatively charged, they repel each other. Which is why sa normal na kidney hindi siya hindi siya nagsispell ng albumin or ng protein into the urine. Okay? But in patients with diabetes na may diabetic kidney disease, pwedeng nawawala yung heparan sulfate dun sa glomerular basement membrane, which is why nawawala rin yung negative charge ng basement membrane. Kasi wala na yung negatively charged na heparan sulfate. So what happens is yung albumin is pumupunta na siya sa ihi, which is why nagkakaroon ng albuminuria in patients with microalbuminuria and eventually macroalbuminuria in patients with diabetic kidney disease. Okay. Anatomy and histology. Okay, so itong patient na to, yung left eye daw niya, na-notice mo na deviated medially. And when you ask him to look laterally to the left, yung eye stays the same, which is medially pa rin. So, what nerve innervates the muscle that is paralyzed? The correct answer is CN6. Okay? Kasi kung ito yung left eye ni Anton, and medially displaced siya, meaning nandito yung mata, and when you ask him to tumingin laterally is hindi niya kaya, it means na ang paralyzed is LR6. It means na ang paralyzed is yung lateral rectus na muscle. There is lateral rectus palsy. And the nerve that innervates the lateral rectus is the CN6. Okay? Which of the following is not derived from Rathkeepa? So correct answer is pars nervosa. Why? Because the pars nervosa is part of the neurohypophysis. Okay? So, which is derived from the diencephalon. So one thing that I want you to know is ang anterior pituitary gland ay may mga secretions siya on its own. Okay, the anterior pituitary gland has acidophils and has basophils. So, ang acidophils, ang pinoproduce niya is GH or growth hormone and prolactin. Ang pinoproduce ng basophils ay FSH, LH, TSH, and ACTH. Okay? Now, it's different from the posterior pituitary gland because the posterior pituitary gland does not produce its hormones. Okay? Yes, may ADH and may oxytocin sa posterior pituitary gland, pero hindi sila napoproduce doon. Napoproduce ang ADH and oxytocin doon sa supraoptic nuclei and sa paraventricular nuclei na makikita mo sa hypothalamus. So from the hypothalamus, doon napoproduce si ADH and si oxytocin, and with the use of proteins called neurophysin, they will get transported from the hypothalamus papunta sa posterior pituitary kung saan sila masastore and marirelease. So ADH and oxytocin is only stored in the posterior pituitary but not synthesized in the posterior pituitary. Pero these hormones are synthesized in the anterior pituitary. Okay? The bullet hit and penetrated the center of its chest at the inferior border of the manubrium. So ano daw yung important anatomical location which is located sa inferior border of the manubrium? The correct answer is sternal angle of Louis. The reason kung bakit ito tinanong is the sternal angle of Louis is an important landmark kasi maraming structures that are found at that level. So, kung ito yung manubrium, Ito yung, and then is the body of the sternum. Ito yung inferior border of the monobrium. Yun yung sternal angle of Louis. Okay? Sternal angle of Louis. Yan. And there are several structures that are in that level. So, for example, yung intersection ng T4 and T5 vertebrae is found there. So, as you can see, ito yung dotted line na to. Vertebra 4, vertebra 5. And the trachea bifurcates into the right and left primary bronchi. So, this is the trachea and this is the left bronchi. So, as you can see, it's within the dotted line ng sternal angle na level. The arch of the aorta arises from the ascending aorta. So, this is the arch of the aorta and it arises from the ascending aorta. Ito yung ascending aorta and then ito yung arch of the aorta. So nag-arise yung arch mula sa ascending and ang marker mo doon is yung this dotted line ng sternal angle, and the arch of the aorta continues into the descending aorta. This is the descending aorta and ito ulit yung level ng sternal angle. The azygous vein drains into the SVC, hindi pinakita dito. And the pulmonary trunk divides into the right and left pulmonary artery na hindi din pinakita dito. But they are also found in that level ng sternal angle of Louis. So this is an important landmark. The most common site of hypertensive hemorrhage is the putamen of the basal ganglia. Vessels involved in this stroke are lenticulostriate vessels, as you can see here. Ito yung basal ganglia. Itong mga slightly gray na figures, and itong pag nagkaroon ka ng hypertensive hemorrhages sa lenticulostriate arteries, they are called Charcot-Bouchard microaneurysm. Charcot-Bouchard microaneurysm yung tawag sa hypertensive hemorrhages. Okay, and the most common site is the putamen, and there are different structures na under ng basal ganglia. We have the putamen caudate nucleus and globus pallidus, and different din sila pag pinagsama. Putamen plus caudate is striatum, putamen plus globus pallidus is lentiform, and you can remember that using the mnemonic straight to the PC, lens from PG. Straight to the PC is striatum, putamen caudate, lentiform, PG, lens from PG is putamen and globus pallidus. Okay, and you also have to remember yung lenticulostriate arteries. Okay, itong lenticulostriate arteries na to comes from the MCA. So pwedeng itanong to kung saan galing kung saan galing na branch of the ICA, internal carotid artery. Saan galing na branch yung lenticulostriate artery? The answer there would be the middle cerebral artery, MCA. The moderator band is found in RV, right ventricle. Actually, wala rin ako mnemonic for this one. But this figure can be useful, no? This is the thing kasi with studying anatomy, no? When you're studying anatomy, you always have to have an atlas beside you so that you can refer to that atlas kung ano man ang sinasabi dun sa text, sa handout ng anatomy. Okay, kasi parang mas madali maalala yung isang structure if you can see it in your mind's eye pag tinignan mo yung atlas as you are reading the handout. Okay? So, kunwari, wala ako mnemonic for the moderator band being found in the right ventricle. But if I see this image and nakikita ko na peeled off itong right ventricular wall and ito yung moderator band, so the next time na itanong siya, mas maalala ko na, okay, nakita ko tong figure na to, I remember it now. I remember it better na the moderator band is found in the RV. Okay? The sartorius muscle is located in which region of the body? The correct answer is letter B, anterior thigh compartment. Okay, so this is the sartorius, itong red na to, which is in the anterior thigh compartment. So aside from knowing that the sartorius is located in the anterior thigh compartment, you also have to know that the sartorius is part of the borders of the femoral triangle. Okay, this is the femoral triangle. Ito. And the borders are itong sartorius, and then itong adductor longus, and then itong inguinal ligament. Okay? And there are structures that are found in the femoral triangle which are from lateral to medial. Okay? From lateral to medial. So the way na parang hindi ninyo malimutan or hindi kayo ma-confuse na lateral to medial or medial to lateral, tandaan nyo itong mnemonic na to, you go from lateral to medial to find your navel, yung pusod. So, you go from lateral to medial para hanapin ninyo yung inyong pusod or yung inyong navel. And the navel stands for nerve, artery, vein, lymphatics. Okay? So, as you can see here, nerve, artery, vein, and then may lymphatics dapat dito. Okay? So, hindi lang pinakita siguro sa figure. But, yun yung mnemonic, no? Navel. Lateral to medial, navel. Femoral triangle, borders of the femoral triangle. Number 7, you were asked to perform Pringle's maneuver to a trauma patient. And then, ginawa mo daw yung epiploic foramen. So, what structures are immediately palpated ventrally and dorsally to the epiploic foramen? The correct answer is letter B, hepatoduodenal ligament and IVC. So, it could be difficult to visualize this image. So, naghanap din ako ng isa pang image na CT scan view. So, as you can see, ito yung epiploic foramen, this one. And ito yung hepatoduodenal ligament, and ito yung IVC. Okay? And imagine mo, when you perform the Pringle maneuver, ito yung kamay mo. Ayan, kamay. Okay, nandiyan yung kamay mo. And, ang hinahawakan mo dyan ventrally is the portal triad. Sorry, not the portal triad, the hepatoduodenal ligament, which consists of the portal vein, the bile duct, and the hepatic artery. That's the hepatoduodenal ligament. That's found ventrally, kasi ito yung anterior, and then ito yung posterior sa likod. Okay? And this is the vertebra, nasa likod. And nasa likod ng kamay mo, nasa unahan is hepatoduodenal ligament, nasa likod ng kamay mo is itong IVC, which is why the answer here, ventrally is hepatoduodenal ligament, and the dorsally, you can find IVC or the inferior vena cava. Okay, number 8. So, as you can see, mas madali mag-aral ng anatomy. Well, for me at least, kung may mga ganitong images, kasi mas nakikita ko siya in my mind's eye. Very difficult talaga mag-remember ng anatomy kung gagawa ka lang lagi ng mnemonic. But there are structures na kahit makita mo, hindi mo pa rin maalala. Tulad nito, kunwari kung hindi mo pa rin ito maalala, kahit may structures na, that's when you use yung mga mnemonics. Okay? Number 8, which cytoplasmic organelle is responsible for steroid phospholipid synthesis, detoxification, and calcium release and sequestration? The correct answer is smooth ER. So the rough ER is responsible for protein synthesis, and yung smooth ER yung responsible for the other functions na mentioned in the question stem. Number 9, all of the following structures originate from ectodermal neural crest. The correct answer is microglia. Okay, so there are several structures that are found or that originates from the neural crest. This is remembered by the mnemonic Elmo passes. But the problem is, kahit maalala mo tong Elmo passes, pwede ka pa rin ma-confuse kung yung M ba stands for melanocytes or does it stand for microglia. Okay? So, I understand that it could be very confusing, but the way I would do this is I would first remember kung ano yung mnemonic, what the Elmo passes mnemonic stands for, and I would specifically tell myself, okay, the M in neural crest stands for melanocytes and not microglia. Okay, medyo sobrang obvious naman na dapat mong gawin yun. But if you do that extra effort na to remember na ang M always stands for melanocytes, pag neural crest, M always stands for melanocytes kung neural crest, it's worth a shot na gawin yon para lang maalala para lang hindi kayo ma-confuse na the M stands for melanocytes and not microglia, because microglia comes from mesoderm. Okay. Number 10, the nerve that innervates the tip of the nose passes through which aperture in the middle cranial fossa? The correct answer is SOF, or superior orbital fissure. Okay, so the way I would remember this, I would look at this image sa first aid. As you can see, it's much better and much easier to visualize it in your mind's eye kung nakikita nyo yung structure. Okay? And napakaganda ng mga illustrations na makikita nyo sa first aid. So, for example, tulad nito, the pink one is the anterior cranial fossa, the yellow is middle cranial fossa, and yung blue is yung posterior cranial fossa. So, As you can see, may corresponding siya na kung anong structure sa makikita dun sa anterior cranial fossa, which is yung red. So sa anterior cranial fossa, you can see the cranial nerve 1, and then from cranial nerve 2 to cranial nerve 6 is yung yellow, and then from cranial nerve 8 papunta sa 12, okay, is itong makikita sila sa posterior cranial fossa, okay? So, kung makita na ninyo tong image na to, it's much easier for you para makita ko nasan yung SOF or superior orbital fissure. Or even if, di ba, alam nyo naman na ang superior orbital fissure, dun nagpa-pass through yung CN3, 4, and 6. Di ba? So, maalala lang ninyo na ang CN3, 4, and 6 ay nandun sa yellow, which is ang yellow is nasa middle, which is yung yellow is yung middle cranial fossa. So maalala lang ninyo 'yun. Parang automatically ililink na ninyo yung location ng CN3, 4, 6 na makikita niyo sa middle cranial fossa, and ma-associate na ninyo na yung superior orbital fissure must also be in the middle cranial fossa. So I hope that makes sense. Yun. So, the superior orbital fissure, as you can see here, is nandito rin sa yellow, sa middle cranial fossa. Okay? Through which the following structures pass through. Okay? So, I hope this image helps you. Number 11, a 67 male consulted in your clinic because of spastic paralysis. There's notable increase in muscle tone, but without fasciculations or atrophy. This is caused by a lesion involving the UMN. Okay? So, it could also be confusing para maalala kung ano ba yung mga signs and symptoms na associated with UMN lesion or LMN lesion or mixed UMN and LMN. So, this is also a very good mnemonic from first aid. So, kung LMN or lower motor neuron lesion, everything is lowered. Lowered muscle mass or less muscle mass, lowered muscle tone, and lowered reflexes and downgoing toes. Okay? Samantalang kung UMN lesion, yung patient ay meron, everything is going up. Increased tone, increased DTR, increased upgoing toes. Okay? So, balik tayo dito. Spastic paralysis, di ba increased tone yon? Okay? Tapos sabi niya, wala raw fasciculations or atrophy. So, walang atrophy. So, less likely LMN, which is why UMN lesion siya. Okay? So, alalahanin nyo tong mnemonic na to. Okay, number 12, which of the following vessels of the circle of Willis is a direct branch of the ICA? The correct answer is, okay, walang answer dito, but the correct answer here should be letter A. Letter C. Okay, letter C ang answer dito, ACA. Okay, as you can see here, this is the internal carotid artery. One branch, ang isang branch ng ICA is the MCA. Another branch of the ICA is the ophthalmic artery, and another branch of the ICA is this one, itong yellow na to, the ACA or the anterior cerebral artery. How about the other choices? Yung basilar artery and pontine and posterior cerebral, nandito sila sa likod. Okay, this is the front and this is the back. The anterior and the posterior. Okay, front, back. So may dalawang vertebral arteries na nandito, and mag-fuse sila para maging basilar artery. As you can see, basilar artery siya. And then the basilar artery will be giving off branches sa may pons, kaya siya tinawag na pontine arteries. And eventually, yung basilar artery will divide into posterior cerebral artery, which is why dito sa choices na to, basilar artery is nasa likod, pontine artery is a branch of the basilar artery, and the posterior cerebral artery is the pag yung basilar artery is nag-divide na. Okay? Okay, so these three are not branches of the ICA. Okay, so as you can see here, this is from BRS Gross Anatomy. ICA, ang branches niya is MCA, ACA, and ophthalmic artery. Number 13, all of the following infrahyoid muscles depress the hyoid except, the correct answer is letter A. So as you can see, lahat ng, so meron tayo, ito yung mga infrahyoid muscles natin. And yan, ang nagde-depress ng hyoid is lahat ng muscles ng apelyedo is hyoid. Apelyedo means itong last name niya. Sternohyoid. So si sternohyoid, si omohyoid, and si thyrohyoid, they depress the hyoid. Samantalang yung ang apelyido ay si thyroid, sternothyroid, hindi siya nagde-depress ng hyoid, ang dine-depress niya yung larynx. Okay? Which is why the answer here is sternothyroid. Number 14, abscess sa third molars. Infection is most likely spread into which cervical space? The correct answer is letter C, submandibular space, as you can see here. So this is the submandibular space. Okay? And pag nagkaroon ng infection dito, it's called Ludwig angina. So this is from BRS Gross Anatomy. Infection of the floor of the mouth, submandibular space, with secondary involvement of sublingual and submental spaces. It is a result of a dental infection, tulad nitong patient natin na to, okay? Number 15. May ST elevation sa leads V1 to V3. You're sure that the infarct is on the anteroseptal wall. Okay, so dun sa, if you are still confused sa mga walls, this is a very good image to look at. V1, so tingnan nyo muna, ito yung tinitingnan ni V1. Ito, V1, V2, V3, V4, V5, and then may V6 dito, okay? Ito yung tinitingnan nila. Yan, itong area na to. Okay? And ang tinitingnan naman ni AVL is it's looking from this side. AVR is looking from this side. And AVF is looking from this side. Okay? And then, yung lead 1, ito si lead 1. Okay? It's looking from this side. Lead 1, lead 2, lead 3. Balik tayo dito. May ST elevation daw sa V1 to V3. Okay? So, kung V1 to V3 ang may ST elevation, ito ang may ST elevation. Saan sila nakatingin? Anterior. This is the anterior. Di ba nandito yung septum? Nandito yung septum. So, it's looking at the anterior and septal wall. Anteroseptal wall. Okay? Paano kung circumflex yung may infarct? Paano kung circumflex, left circumflex artery yung may infarct, no? The left circumflex artery is makita nyo mo yung ST elevation sa V4, V6. Nasaan ba ang circumflex artery? Nandito yung circumflex artery sa may tabi. And ang tumitingin sa kanya is si V4, si V5, and si V6. Which is why V4, V5, V6 yung may ST elevation pag may left circumflex artery infarct. And it's the same thing with inferior wall. Di ba pag inferior wall infarct is 2, 3 AVF. Why? Kasi ito yung inferior wall of the heart. And ang tumitingin sa kanya ng mga leads ay si 2, si 3, and si AVF. Okay, so this is a very good image. Okay. Number 16, which of the following structures is the adult derivative of the urachus? The correct answer is median umbilical ligament. Okay, it could be confusing kasi may median umbilical ligament and may medial umbilical ligament. So the way I would remember this is median, letter N. Ito yung median, letter N. Binabaliktad ko siya upside down, magiging U. Median umbilical ligament is urachus. Okay? Median umbilical ligament, urachus. Medial is umbilical. Okay? Medial umbilical ligament is a remnant of the umbilical artery. Okay? Pareha sila na al. Okay? Ito naman median is N, upside down, U, urachus. Okay? Mr. C was enjoying his hot pot dinner, aspirated material. So, nakaano siya? Most likely nakaupo si Mr. C. Okay? So, wala naman kumakain nakahiga or lying on the right side. So, nakaupo siguro si Mr. C. Aspirated material most likely lodged in the letter B, right lower lobe. Wala akong mnemonic dito, guys. Sorry. Hanapin nyo lang muna yung similarities. Like, for example, supine, which is nakahiga, and upright, ay parehas na right lower lobe. Okay, parehas na right lower lobe si supine and si upright. The only difference is, si supine ay, pag nakasupine yung patient, is a superior segment ng right lower lobe, papasok yung aspirated material. Upright, supine, parehas na right lower lobe. Supine, the only difference is supine is superior segment of the right lower lobe. Pero pag lying on the right side, right upper lobe, hindi right lower lobe, right upper lobe, pag lying on the right side. Okay, so medyo confusing, but pag lagi nyo siyang pag nakikita yung similarities, like for example, supine, upright, nakita yung similarities na right, RLL, and then lying on right is RUL, mas madali siyang maalala pag nakita nyo yung patterns, no? Number 18, Okay, so she complained of wrist pain, dorsiflexion, abduction of the hand. Which carpal bone was most likely fractured? The correct answer is letter B. Tinatanong lang dito what is the most commonly fractured carpal bone? The answer for that is scaphoid. Okay. So, again, as I said kanina, sa PLE, pwedeng ang tinanong last time what is the most commonly fractured carpal bone? It's scaphoid. So sa next question, no, sa next PLE, kung yun ang tinanong sa last PLE, ang pwedeng itanong sa next PLE is hindi ulit yung most commonly fractured carpal bone, which is scaphoid. Ang pwede nang itanong is saan palpable, saan anatomic landmark palpable yung scaphoid. Pwedeng yun na itanong. About scaphoid pa rin, but hindi na yung exact question. Ang tinanong na is, saan anatomic landmark palpable si scaphoid? The answer to that is the anatomic snuff box. Okay? So this is again from first aid. So what is the anatomic snuff box? It has 3 borders. Tatlong tendons ang nagbo-border sa anatomic snuff box. We have the epal. So this is how I say it sa utak ko, no, para mas madali. The epal, the epub, and the abbol. Okay? Epal is extensor pollicis longus, epub or extensor pollicis brevis, EPB, epub, and then abbol, okay? Hindi adpol, abbol. Kasi abductor pollicis longus, abbol. Okay, so sila yung tatlong tendons na nasa anatomic snuff box. This is the anatomic snuff box, okay? As you can see here, ito yung anatomic snuff box, okay? Yung triangle na yan. So hindi siya box, triangle siya. Anatomic snuff box. It is dyan mo makikita yung scaphoid, which is the most commonly fractured bone. And you also have to know, kasi baka itanong sa PLE sa October, is yung complications ng proximal scaphoid fractures, which is AVN and non-union dahil retrograde yung blood supply. So ang isa pang pwedeng itanong, saan galing yung blood supply ng scaphoid? The correct answer is radial artery. Okay. And the complications of a proximal scaphoid fracture are AVN and non-union. Okay. And aside from that, you also have to know kung ano yung mga carpal bones, which is remembered by this mnemonic. Abdominal policeman. Okay, so the correct answer is omentum. Now, I wasn't able to find itong abdominal policeman na word sa gross anatomy ng BRS. Maybe because medyo luma na siya na terminology. But I think this is from Ken Hub. And it says na the reason why the greater omentum is called the abdominal policeman is number 1, it prevents the sticking of the parietal peritoneum to the visceral peritoneum. And kung may inflammation such as the appendix, it protects the healthy organs in the abdomen. So, yun, policeman nga siya kasi parang kinokontrol niya yung situation. So, kung may inflammation of the appendix, pinoprotect niya other healthy organs in the abdomen from the inflamed appendix. Okay, number 20, the female homology of the prostate gland is letter B, skin glands. So, okay, this is also one of the most important na tables na dapat nyo maalala for anatomy. Now, ang problema dito, wala rin akong mnemonic for this. Nalimutan ko na kung meron man. And actually, limot ko na rin to. So, naghanap ako ng maka-help sa inyo na I hope na image. So, gawan nyo lang to ng kwento. So, kung ako personally gagawa ko to ng kwento, so, in-imagine ko, si corpus spongiosum, ang kanyang female homolog, is si vestibular bulbs. So kung ako alalahanin ko to. So I imagine na mayroon akong sponge na may water na pinopour na ini-squeeze ko and inaano ko dun sa bulbs. Parang binabasa ko yung bulbs, no? Ini-squeeze ko and then the water is nag-flow downwards papunta dun sa bulbs. Tapos nakuryente ako kunwari. So vestibular bulbs, no? So yon. So that's the way I would remember it para hindi ko malimutan kasi mas marami akong senses na ini-engage, like maririnig ko yung sparkling yung sparkling ng kuryente nung nakuryente ako, and then maririnig ko yun, then makikita ko yun, and then syempre yung emotions na nararamdaman mo na anxiety and fear na baka makuryente ka. So yun, so, ganun ko siya naalala, no? And then, Cowper glands. So, imagine mo, si Cowper glands is Cowperman. Cowper, Glance Cowperman, sinasave niya itong matandang raccoon na to, itong Lola raccoon na to, na pangalan niya si Bartolina. Ito, hindi ko alam kung anong pwedeng kwentong magawa ninyo sa prostate and sa skin glands. Ito si penile urethra, tingnan mo. Yung penile urethra is mukha lang siyang gripong maliit, kaya maliit lang din na lips ang pwede mong ipangsubo dyan sa penile urethra na maliit lang din. But, kung may malaki kang basket na may mga eggs, dapat malaki rin yung mouth mo para isubo itong malaking eggs, basket ng eggs na to, no? So, medyo, medyo may pagkabastos and medyo nakakatawa. Pero that's the way kasi, the more, the funnier, the more out of this world, the more lewd yung mnemonics ninyo, the more na maalala ninyo yung mga itong mga ganitong types of information na hindi intuitive. Okay?
Hello everyone, my name is Dr. Gabriel Flores. You can just call me Gabby, and this time I am back, not to discuss pharmacology, but to help with the discussion of your midterm exams. So your midterm exams were created by Dr. Jessica Castillo, and I and Doc Carl Avilio will be discussing the rationale, the questions, and the answers for your exam. So I hope that you're all feeling good and confident after having taken the midterm exams. Doesn't matter if may mga mali sa questions, that's to be expected. What's important is we don't repeat those mistakes during the actual exam, and we know the rationale behind the answers so that if lumabas man yung concept ulit kahit na hindi exact question, we know how to approach the topic, we know how to apply testmanship, and we know how to answer those questions correctly. Okay, so let's start with our microbiology and parasitology. So first question, the following are cells of the adaptive immunity except your T cells, antibodies, CD4 cells, or your neutrophils. So we know our answer here is letter D, your neutrophils, because your neutrophils are members of your innate immunity, whereas the rest of the choices, T cells, antibodies from B cells, CD4 cells, which are a type of T cells, a type of T cell, are all members of your adaptive immunity. So let's refresh ourselves. Remember that an immune system responds to a pathogen or a foreign body by mounting what we call an immune response. Now, this immune response can either be from your innate immunity or your adaptive immunity, and they have very different features because they have very different roles as well in immunity. So innate immunity, everybody has it. It is the first line of defense against any infection or pathogen. Therefore, because it's the first line of defense, it has to be really quick, very rapid. Sorry. There we go. It has to be very quick and very rapid. Because it is very quick and very rapid, it doesn't really have time to care who or what the pathogen is. It just knows it needs to attack. Therefore, it is non-specific. Mabilis mag-attack, mabilis rin makalimot. It has no memory response. Okay, so it's your first line of defense. It doesn't care what or who it's attacking. It just knows it needs to destroy that pathogen. So members of your innate immunity include your neutrophils, your macrophages, your monocytes, your dendritic cells, which are your antigen-presenting cells, your NK cells, which are the primary cellular components to combat microbes. You also have, of course, physical barriers like your skin or your mucosal membranes and secreted enzymes. Okay, now compare this to your adaptive immunity. So your adaptive immunity, from the name itself, it takes some time for it to adapt and to mount an immune response. It is not first line. Therefore, it is refined over time. So as a first line of defense, it's not going to do much. But as a second, third, and fourth line of defense, it's going to be very good. So what happens is the innate immunity buys time for the adaptive immunity to recognize the pathogen, understand who or what the pathogen is, and eventually develop a highly specific, faster, and more robust immune response. So what are examples of our adaptive immunity? So remember that we have your T cells and your B cells, diba? Remember that your lymphoid cells play a massive role in the adaptive immunity. So your T cells, T for thymus, they grow and mature there. And your B cells, B for bone, in the bone marrow. So what is this variation through VDJ recombination? So essentially, it's just variable diverse joining recombination. What that means is the chains in the T cell receptors rearrange, and that allows T cells to have your subclasses, either CD4 and CD8. Remember also that your circulating antibodies, okay, These occur whenever a T cell recognizes an antigen bound to your class 2 MHC or major histocompatibility complex from your antigen-presenting cells. It releases cytokines and it tells your B cells to please differentiate into plasma cells. And then your plasma cells then express these antibodies or immunoglobulins. So remember that these are highly specific, are more robust, and also have a better memory response. Okay? Next, Melody, a 7-year-old female, came into the emergency room complaining of back pain, joint pains, rashes, lymphadenopathy, and fever. The most likely vector of this infectious disease is A. Aedes aegypti, B. Plasmodium falciparum, C. ticks, or D. Aedes albopictus. So before answering that question, let's go to the next question because this is a cascading set of questions. Your diagnosis for the above question is A. Chikungunya, B. Dengue fever, C. Yellow fever, or D. Zika virus. So this is one of those questions that if you get one wrong, you're likely to get the other wrong as well. So our answer for number 2 is letter A, Aedes aegypti, because we know that Aedes aegypti, especially in the Philippines, is the most common vector of your dengue fever or your dengue virus. Okay, so let's review our dengue and our other vector-borne viral diseases. So the key word that was mentioned in the stem, and this is really important for your testmanship if we go back, is back pain. So remember that joint pains, rashes, lymphadenopathy, and fever, they're very nonspecific. Fair, back pain is also nonspecific, but we need to test our testmanship for the purpose of boards. And when you see back pain in a young child who has a fever and other symptoms of dengue, definitely think of dengue. So remember that dengue in Harrison's is even called break bone fever. And in your Nelson's, it's even called back break fever. Okay, back break fever. So this gives you a clue as to what they're looking for in the question stem. Because it mentioned back pain, and of course the question stem was set in the Philippines, we must assume that it was referring to your dengue fever. So there are other signs and symptoms of dengue like headache, leukopenia, occasionally a biphasic or a saddleback fever where it fever rises, and rises again. Now, it shares a lot of similarities with your chikungunya, for example, which presents with severe polyarticular migratory arthralgias, especially involving the small joints, hands, wrists, and ankles. So remember, in the question stem, it didn't really talk about your hand, wrist, or ankle involvement. Rather, it highlighted the back pain. So that is our clue that it was referring to dengue fever. And of course, we know that dengue fever, the most common vector in the Philippines, is your Aedes aegypti. Okay? You are suspecting a staphylococcal skin infection in a 3-year-old boy who is tachycardic, febrile, and hypotensive despite IV fluids. What test will you request to confirm the etiologic agent? Is it anti-DNase, ASO, or anti-streptolysin O, C, blood culture, or D, would you swab the lesions for molecular testing? So our answer here is letter C. So why letter C? Look at the question stem. The question stem is showing a patient with signs of sepsis from a staphylococcal infection. He was tachycardic, he was febrile, he was hypotensive despite giving fluid resuscitation. Now, if a patient is septic, definitely order blood cultures. And if we're suspecting that staphylococcal infection is the cause of this patient's sepsis, according to Jowett's, a surface swab pus or aspirate from an abscess, blood, ET aspirate or sputum or spinal fluid, wherever you think this focus of the infection is, for culture are all appropriate specimens for testing. In addition, the question stem asks specifically, what tests will you request to confirm the etiologic agent? So you want to know what exactly is causing this infection. And whenever it comes to confirming which bacteria it is, the most sensitive and the most specific, and usually, not all the time, but usually the gold standard is your culture. Okay, now what about anti-DNase and ASO? So remember that we don't really use this to diagnose staphylococcal infections, and we definitely don't use it to confirm the etiologic agent because streptococcal infections also have anti-DNase and ASO. Where do we use anti-DNase and ASO? Remember, we use it as evidence of a preceding step infection. If it was strep pharyngitis, we use your ASO or your anti-streptolysin O. And if it was a preceding skin infection, we tend to use anti-DNase. And again, we do this in patients who present with rheumatic fever. So it is not used for confirming staph as an etiologic agent. What about letter D, swabbing the lesion for molecular testing? This will be useful for helping us determine whether or not the staph is methicillin resistant, so MRSA, or whether it is susceptible to certain antibiotics. But we will not use it to confirm the etiologic agent. The best answer here is C. Okay? Andy spent his summer vacation in a private resort at El Nido, Palawan, where there is scarce potable water supply. He developed diarrhea with stools he described as parang pinaghugasan ng bigas. What is the mechanism of action of this toxin? Does it inhibit GI protein? Does it activate GI protein? Does it activate CAMP? Or does it inhibit CAMP? So the best answer here is letter C. So we know sa diarrhea na mukhang rice water or parang pinaghugasan ng bigas, that is your buzzword for cholera. And we know that the cholera toxin increases levels of CAMP. So since increasing CAMP is not in the choices, our best answer would be activate CAMP. So remember that Vibrio cholera causes the watery diarrhea in large volumes, the rice water stool as your buzzword. It's transmitted fecal-orally, and the treatment is 1, really aggressive fluid and electrolyte replacement, and 2, tetracycline or azithromycin, because it has been shown to both shorten the duration of the disease and also prevent transmission of the bacteria to other people. Now, in terms of the bacterial exotoxins, remember that the cholera toxin, what it does is it has 2 subunits. It has the A subunit and the B subunit. The B subunit is what attaches to the receptor in your intestine cells, okay? And once the B unit attaches to the receptor, the A unit or the attack unit enters the cell. What the A unit of the cholera toxin does is it overactivates adenylate cyclase. And we know that when you stimulate adenylate cyclase, you cause increase in your CAMP. And when you increase your CAMP in your intestinal epithelial cells, what happens is you have increase in chloride secretion from these cells. So these intestinal cells keep on secreting chloride, especially from your crypt cells. So what happens to the inside of the epithelial cell? It makes the inside of the cell very positive because chloride is negative. So if the inside of the cell is very positive, can sodium enter the cell? Remember, sodium is a positive ion. No, it won't. So you're losing lots of chloride. You're not reabsorbing sodium. And remember, where sodium goes, water follows. So you're losing massive amounts of water. So most of the time, patients who die from cholera die because of severe dehydration and shock, hypovolemic shock. Okay. Next, the most sensitive test for diagnosing trichomoniasis is A, culture, B, ELISA, C, history and physical examination, or is it D, your wet mount? So note, guys, that it was asking not what you would order in the first instance, but what the most sensitive test was. And our answer is letter A, culture. So why culture, doc? So Trichomonas vaginalis, remember, it's a urogenital amoeba and it causes your trichomoniasis, which is a sexually transmitted infection. As an initial diagnostic tool, absolutely, you would do a direct microscopy with wet mount. However, the question was asking about what is the most sensitive. Now, the most sensitive test, according to your blueprints, is your culture. And with what medium? It's your diamond medium. Okay, so the initial diagnostic, which is your direct microscopy, usually it will show the diagnosis, but there are cases where there are false negatives, so it's not that sensitive. In which case, you would then do a culture, or which is the gold standard, the most sensitive and the most specific. Now, what is the clinical presentation of your trichomoniasis? It's greenish, foul-smelling discharge. There would be small red punctate dots on the cervix, and that's what we call your strawberry cervix. The pH is usually over 4.5. And how do we treat it? We treat it with metronidazole or tinidazole as a 2-gram single dose. We treat both the patient and the patient's sexual partner, even if the sexual partner is asymptomatic. Okay? Which statement correctly describes the pathogenesis of elephantiasis? Is it A, dead adult worms in the lymph tissue cause fluid shifts? B, microfilariae in the blood cause inflammation, C, electrolyte disturbance, or D, adult worms trigger inflammation in lymphatic vessels? Our answer here is letter D. So the adult worms trigger inflammation in lymphatic vessels. So filariasis or elephantiasis, what's the pathogenesis here? So first, the larvae reach the lymphatic vessels and the lymph nodes where they develop into your adult worms. Now, the adult worms in the lymph nodes trigger an inflammatory response from our immune system. And this inflammatory response causes thickening, stricturing, and eventually blocking of the lymphatic vessels. Therefore, it is unable to adequately drain your lymph fluid, and therefore you get lymphedema. So the microfilariae do not cause symptoms. So remember, we have two types. You have your Wuchereria and your Brugia. So the Brugia, I remember it as Bruja because you have to remember that the appearance is kinky, whereas the appearance of your Wuchereria is smoothly curved. Another thing that's really important to remember between the two of them is what happens whenever you get infected with either the Wuchereria or the Brugia. So remember Wuchereria, W, it looks like a very big scrotum. So that will remind you that it causes massive hydrocele, whereas your Brugia causes lymphatics to be obstructed and causes your elephantiasis. Okay. Mimi traveled to Palawan for the first time to attend a wedding. After 7 days, she developed high-grade fever and chills. What parasitic stage is most likely present during this febrile stage? Is it A, sporozoites, B, hypnozoites, C, merozoites, or D, your gametocytes? So first, let's diagnose what are the buzzwords. Palawan, high-grade fever, chills, parasitic stage, so we're thinking of malaria. And the parasitic stage of malaria associated with the occurrence of the fever is your merozoites. So, okay, let's review a bit of the life cycle of your Plasmodium. So remember that the Plasmodium, there are several types of species. These are what cause malaria. The areas in the Philippines with high endemicity, please remember Palawan, Kalinga Apayao, Ifugao, and Agusan del Sur. Now, the blood stage parasites, which are your merozoites, are those that cause the symptoms of malaria. And the pattern of fever, so remember, malaria doesn't cause daily fever. It causes fever every 24 hours, every 48, or every 72 hours. And the pattern of fever is dependent on how often the schizons rupture to release merozoites into the blood. So let's just have a quick refresher of the malaria life cycle. So let's start with the mosquito taking a blood meal. So when the mosquito takes a blood meal, it injects the sporozoites into the bloodstream. When the sporozoites go into the bloodstream, they actually first enter an exoerythrocytic cycle, which means outside the red blood cell. They go to the liver cells, they infect the liver cells, and they multiply and mature into your schizons. So your schizons are essentially big bags containing tiny little merozoites, okay? So once these schizons become larger and larger, they rupture and they release these tiny little merozoites into your bloodstream. And so we enter the erythrocytic cycle or the red blood cell cycle. So the merozoites quickly invade the red blood cells or your erythrocytes. And once inside the red blood cell, they multiply and undergo a series of developmental stages, which eventually all just leads to creating another schizont, rupturing the schizont, and releasing more and more merozoites into your bloodstream. Okay, they can also mature into your gametocytes, which if a mosquito takes another blood meal, it ingests the gametocytes. The gametocytes then mature inside the mosquito until it once again becomes a sporozoite, which can then infect other people. Okay. So remember that we have different species of your Plasmodium. We have your Plasmodium knowlesi, falciparum, vivax, ovale, and your malariae. Usually, we can differentiate them by how they appear under the microscope, but clinically, we can also look at how toxic the patient is and how often the fever occurs. So take, for example, your Plasmodium falciparum versus your Plasmodium vivax and ovale. So all three of them occur every 48 hours. So that means that on the third day, you develop a fever, and then you get defervescence, so the fever breaks, and then on the third day again, you get a fever. So Plasmodium falciparum is known to be more toxic, so that's why we call it the malignant tertian malarium or malignant tertian fever, whereas the vivax and ovale are known to be a bit less toxic and they are called the benign tertian fever. Now, the reason that Plasmodium falciparum is known to be more toxic to patients or known to be more toxic to people it infects is because it has a preference for all ages of red blood cells. So whether it's a mature or a young red blood cell, it is able to infect it. Compare that to your Plasmodium vivax and ovale, which tends to prefer your young red blood cells only. Okay. What else is special about your Plasmodium vivax and ovale? So remember, they are also the ones that have hypnozoites. So ito yung parang sleeping version of the parasite that they just stay in the liver for prolonged periods of time, not causing any trouble. Hypno, sleep. So they're just asleep in the liver until they decide to randomly wake up again and wreak havoc on your system. So the classical malaria paroxysms, you have the cold, the hot stage, and the sweating. So the cold stage usually starts with shivering, peripheral vasoconstriction. So usually the peripheries become quite cold to touch. And then you have the hot stage, which is your headache, your palpitations, your tachypnea, your high fever, until eventually the fever breaks with diaphoresis or cold sweats and defervescence, the breaking of the fever. Then that cycle continues again and again, depending on which type of Plasmodium infected you, either every 24 hours, 48 hours, or 72 hours. A 30-year-old male came into the ER with fever and change in mental status. Upon history, you found out that he lives in a house frequented by pigeons. He has been on highly active antiretroviral therapy for 1 month now. Your most likely consideration would be A, cryptococcal meningitis, B, histoplasmosis, C, coccidiomycosis, or D, bacterial meningitis. So we have quite a few buzzwords in the stem that I hope you picked up on, and our answer here is letter A, cryptococcal meningitis. What are the buzzwords? This patient has been on HAART, highly active antiretroviral therapy, meaning this patient has HIV or AIDS and is likely immunodeficient. The second buzzword is your pigeons. So we know that Cryptococcus loves to be in pigeon poo. And the fever and the change in mental status suggests that there is both meningitis and encephalitis going on. So remember, in Cryptococcus neoformans, this is an oval yeast with a narrow-based bud surrounded by a very wide polysaccharide capsule. And it is this wide polysaccharide capsule that becomes very visible when you do the India ink preparation, because the polysaccharide capsule doesn't take up the India ink. So you can see it as a massive area of lucency around the yeast. You can also test for it using the latex agglutination test, where you collect a sample of the patient's CSF, for example. You mix it with some latex beads, which are coated with antibodies specific to Cryptococcus neoformans. And whenever Cryptococcus is present, these latex beads clump together or agglutinate. So remember that transmission of Cryptococcus neoformans is via inhalation of your airborne yeast cells, and these yeast cells grow abundantly in soil containing bird or pigeon droppings. So patients who have lots of birds or lots of pigeons at home, especially if they are immunodeficient, are at risk. So the clinical spectrum can be either meningitis, so they would present with meningeal irritation signs, fever, positive Brudzinski's, Kernig's, etc., and encephalitis, meaning you're presenting with altered mental status, change in personality, etc. So Cryptococcus neoformans is the most common cause of meningoencephalitis in HIV patients. And how do we treat it? We treat it with amphotericin B, which we know is a very strong antifungal medication, and flucytosine. And for patients with a CD4 count of less than 100, meaning their immune system is absolutely shot, we can give a chemoprophylaxis with fluconazole. Next question. Eunice has been recently diagnosed with streptococcal prosthetic valve infectious endocarditis. How long should you prescribe antibiotics for treatment? Is it 10 weeks, 8 weeks, 4 weeks, or 6 weeks? So the answer here is letter D, 6 weeks. So treatment duration for infective endocarditis was apparently asked multiple times in this recent March boards. However, they did not specify which organism and whether or not the case involves a prosthetic valve. However, if it does come up again and it does indicate a prosthetic valve, do know that according to your Harrisons, for prosthetic valve endocarditis, a 6-week regimen is preferred. Okay, so 6 weeks for prosthetic valve endocarditis. Cheryl just found out that she's pregnant. She's sure that her husband practices monogamy. However, she tested positive for syphilis. She asks you what are the possible pregnancy-associated complications of this disease. All of the following are correct except spontaneous abortion, saddle nose, hydrops fetalis, or neonatal ophthalmia. So our answer here is letter D. Why letter D? Where do we see neonatal ophthalmia? More commonly, we see it in gonorrhea and chlamydia infections, not in syphilis. So remember that syphilis is caused by your Treponema pallidum. It can result in stillbirth and hydrops fetalis. If the child survives, they can present with several facial abnormalities. That includes your notched teeth, your saddle nose, which is a flattened nose caused by destruction of the cartilage, a short maxilla, saber shins, and cranial nerve 8 or sensory neural deafness. So congenital syphilis, when presenting in this manner, usually is called your snuffles. Okay? Now, your neonatal ophthalmia, or another term for it is ophthalmia neonatorum, remember, is most commonly caused by gonorrhea with or without chlamydia. Next question. After attending Taylor Swift's concert in Japan, Dorothea developed sore throat, fever, and cough. The causative agent of Dorothea's disease is known to have this receptor in the human body. Is it A, VCAM, B, ACE2, C, CD21, or D, P antigen? So we know the answer here is letter B, ACE2, because the stem is pointing us towards a COVID infection. So I know it's very non-specific, but we have to go with the best answer. Let's also eliminate the other options. We know that it's not CD21 because CD21 is used by your EBV or your Epstein-Barr virus. Remember, you have to be 21 to enter a bar. Is this patient presenting with symptoms of mono or mononucleosis? Diba hindi naman. With P antigen, with the mono, yes, you can have sore throat, fever, and cough, but there's no mention of any enlarged lymph nodes. Your P antigen, remember the P's of parvovirus, P antigen, parvovirus, and progenitor red cells. Usually in adults, this presents with headaches, etc. And in young children or in utero, it can present with hydrops fetalis. Or in patients who have a pre-existing hemolytic disease, it can present with aplastic anemia because it attaches to the P antigen in the progenitor cells of your erythrocytes. So the best answer here is your ACE2. Okay. Remember that SARS-CoV-2 is a causative agent of COVID-19. It is known to bind to the ACE2 receptors, which are highly expressed on the pulmonary epithelial cells, allowing the virus to replicate and spread within the body. Next question. Which of the following features help distinguish group A streptococcus from other streptococcal species? Is it A, growth inhibition in 6.5% sodium chloride, B, bile solubility, C, optochin sensitivity, or is it D, bacitracin susceptibility? So what distinguishes gas? Remember, it's your bacitracin susceptibility. So let's never forget this flow chart on your gram-positive bacteria. If we zoom in to the bacitracin sensitivity, it is what differentiates your Streptococcus pyogenes, your gas, your group A streptococci, versus your group B streptococci like your Streptococcus agalactiae. So remember that Strep pyogenes is sensitive to bacitracin and Strep agalactiae is not sensitive to bacitracin. So guys, if you forgot this flow chart, please take a second to pause and go through it. Go through the flowchart, really try to memorize it because it is a really important one for the purpose of PLE. Stella from the book adaptation movie 5 Feet Apart is diagnosed with cystic fibrosis. She's aware of the possibility of recurrent infection with bacteria such as Pseudomonas because of respiratory tract changes that include A or an decrease in mucus secretion, decreased lysozyme secretion, decrease in pH, or increase in thickness and viscosity of secretions. So we know the answer here is increase in thickness and viscosity of secretions. So remember that in cystic fibrosis, you have an abnormality of your CFTR or your cystic fibrosis transmembrane protein, conductance regulator protein. So essentially what happens is CFTR usually allows chloride and bicarbonate to be released, and with this is followed by water. So this allows your mucal secretions to be both basic or alkaline and also quite fluid. And this also promotes the mucociliary elevator, which is your cilia in your respiratory tract beating up pathogens so that you can cough it out of your system. So in the absence or in the abnormality of this protein, you get really, really thick viscous secretions. And we know in pathology, whenever you block something with thick viscous secretions, you promote stasis of this fluid. Whenever there's stasis of fluids, secretions, or mucus, you are so much more prone to infections. Like in your gallbladder, diba? If you block the gallbladder duct or the common bile duct, you produce stasis and sludge of the gallbladder. You produce stasis and sludge within the gallbladder, and you increase the risk for cholecystitis or cholangitis. So the 3 most common bacterial infections in patients with cystic fibrosis, so in young children and infants, it's your Staphylococcus aureus, okay? In adults, it's your Pseudomonas aeruginosa, and generally, it's your Streptococcus pneumoniae. Another bacteria that you need to know in patients with cystic fibrosis, it's not the most common, but it is notorious because when present in patients with CF, it reduces their life expectancy and increases mortality rates. And that's your Burkholderia cepacia. Okay. Next, a 12-year-old boy has a painful arm that he injured while pitching a full court assist in a basketball game. The pain has gotten worse over a 2-week period, and he now has a temperature of 37.8 degrees Celsius. X-ray revealed a raised periosteum. Aspirate of the lesion reveals gram-positive cocci in clusters. What is the most likely cause of the boy's illness? Strep pyogenes, Staph aureus, Strep aeruginosa, or your Strep agalactiae. So we know the answer here is this patient has osteomyelitis. So the answer here is Staph aureus. Okay. So if there is no other information given and the patient does present with osteomyelitis, assume it is from Staph aureus for the purpose of the boards. If the patient is sexually active, technically Staph aureus is still the most common amongst patients who are sexually active. But if the stem is giving you a lot of clues, this patient is very sexually active, has signs and symptoms of chlamydia or gonorrhea, then you would think of your gonococcal osteomyelitis caused by your Neisseria gonorrhea. In patients with sickle cell disease, think of your salmonella. In patients with prosthetic joint replacement, think of your Staph epidermidis, especially if it's subacute, meaning it's not immediately after the operation. Think of Staph epidermidis. If there's vertebral involvement, so if it's acute, meaning it happens very quickly, the patient becomes very toxic, again, it's usually Staph aureus. But if it's subacute, happens over the course of several weeks to several months, think of tuberculosis. After a cat and dog bite, if you develop osteomyelitis, the question stem is probably leading you towards Pasteurella multocida. And in patients who are IV drug users, it's usually multiple organisms. So your Staph aureus, your Pseudomonas, and your Candida. Okay, so staphylococcal osteomyelitis can be either from hematogenous spread, so from the bloodstream, it goes into the bones, or via local introduction at a wound site. So I'll discuss the Brody abscess in a later question. Next, etiologic agent of Cochin China diarrhea. Is it your Capillaria philippinensis? Is it your Trichuris trichuria? Is it your Ascaris lumbricoides? Or is it your Strongyloides stercoralis? So Cochin China diarrhea, our answer here is letter D, Strongyloides stercoralis. So your strongy or your threadworm, remember it's one of your soil-transmitted helminths. It is one of the parasites that exhibit your heart-lung larval migration. And it causes what we call Cochin China diarrhea, which is intermittent, watery, and bloody diarrhea. So another thing that is to note about strongyloides is it also causes hyperinfection or autoinfection in the immunocompromised state. So in patients who have HIV/AIDS or in patients who are recipients of a solid organ transplant and are therefore immunosuppressed, they can present with autoinfection. And the way autoinfection happens is typically your rhabditiform larvae in the intestine are excreted into the stool. However, in patients who are very immunocompromised, even without having exited the body, this rhabditiform larvae can develop and mature into the filariform larvae, which is the infective stage. And it enters the perianal mucosa and the intestinal mucosa, so that even if it doesn't leave the body, it just reinfects the immunocompromised person. So it can also cause your ground or your dew itch, and it also causes your Loeffler syndrome because of its ability to migrate to the lungs. Which of the following diseases is best diagnosed by serologic means? Is it your Q fever, your gonococcal infection, your tuberculosis, or your actinomycosis? So the best answer here is your Q fever. So let's quickly discuss your Q fever. Remember, it's caused by your Coxiella burnetii, and it is best diagnosed serologically, and it is evidenced by a rise in antibody titers. One of the reasons we don't do cultures with Q fever is 1, it's usually culture negative, meaning it won't show up on cultures, and 2, you need a level 3 biosafety lab in order to process cultures of Coxiella burnetii because it can be used in bioterrorism and is a massive biohazard as well. So it's the only rickettsial disease that does not require an arthropod vector for transmission. Transmission is done via inhalation of the bacterium from the urine, feces, or placenta of your livestock, your cattle, and your sheep. So farmers who are immunocompromised are at a very high risk. It does not present with your rash. It will present with a fever, headache, feeling generally unwell, malaise, etc. And in the chronic phase of Q fever, so if you get chronic Q fever, the most common presentation is actually culture-negative infective endocarditis, meaning a patient will meet the Duke's criteria for infective endocarditis, but all the cultures will be clean or sterile. In which case, you would check the antibody titers for Coxiella burnetii, and you would see a rise in antibody titers supporting your diagnosis of a Coxiella burnetii infection. Has quite a high mortality rate if not treated properly, and the treatment for Coxiella burnetii infections is your doxycycline. And if it's in the chronic phase of Q fever, the treatment can take up to 18 months to really eradicate the bacteria. Question. So this structural protein seen in HIV is responsible for viral fusion and entry. Is it GP120, GP41, GP24, or GP27? So remember, for viral fusion and entry, it's GP41. So really important, the structural genes of the HIV genome, the 3 genes you really have to remember are GAG, POL, and ENF, okay? GAG, POL, and ENF. So for this question, let's focus or zoom in on your ENF gene, which codes for your GP120 and GP41 proteins. So look at the figure below. GP120 is the protein that attaches to your CD4 receptor. And once attached to the CD4 receptor, you have to find a way to fuse the cell membrane to create a fusion pore so that the virus can enter the CD4 cell. Now, the fusion pore, what's responsible for this is your GP41. So, okay, GP120 attaches to the CD4 receptor. GP41 creates this fusion pore to cause fusion with the host cell. Which of the following is not a characteristic of the organism that causes a respiratory infection common among Filipinos, which presents as cough, weight loss, night sweats, and a chest x-ray finding with predilection on the upper lung lobes? Okay, acid-fast rods can cause extrapulmonary infections, contains cord factor or no known drug resistance. So the question is asking which is not a characteristic. So we know the answer is letter D. So definitely maraming drug resistance on tuberculosis, which is why we give multiple drugs in the treatment of tuberculosis. So remember, quick refresher on Mycobacterium tuberculosis. It is a slender, aerobic acid-fast rod. So what does acid-fast mean? It means it is resistant to the decolorization step in the staining process using acid-fast stains like your Zeal-Nielsen stain or the Keen-Yoon stain. So it has a very high lipid content in its waxy cell wall. It contains lots of mycolic acid, and this is what is responsible for its acid fastness. It stains bright red because it is able to retain the carbonyl fusion stain used in identifying acid-fast bacteria. It produces catalase and niacin, and it also has cord factor as one of its most important virulence factors. So what does cord factor do? It, one, promotes evasion from the immune system by inhibiting white blood cell migration. And it also induces TNF-alpha release. And it is this TNF-alpha release that contributes to the massive tissue damage and lung pathology associated with tuberculosis. So remember, the treatment due to the development of multiple drug resistance, we always give combination antibiotics to target TB. Last question for microbiology. What is the most common site of osteomyelitis caused by Staphylococcus, which often develops as a sequestered focus known as your Brodie's abscess? So our answer here is your metaphysis. Okay, so in particular, the metaphysis of your long bones like your femur and your tibia. The reason this is the favorite place of your Staph aureus and other bacteria to cause osteomyelitis is the metaphysis has a very, very rich blood supply, making them susceptible to hematogenous or blood-borne spread of your Staph aureus. Now, the Brodie abscess is a sequestered focus of osteomyelitis, usually arising in the metaphyseal area of a long bone as seen here. Okay, and that's it for your microbiology and parasitology questions. Okay, now let's move on to your physiology. Okay, starting with question number 1. Eve was a neurooscate patient. She was unable to rapidly alternate between tapping the palm and the dorsum of her left hand. Where is the lesion? Is it A, the cerebellum, B, the medulla, C, the pons, or D, the thalamus? Our answer here is letter A, cerebellum. So itong unable to rapidly alternate between tapping the palm and the dorsum of her left hand, that's describing your dysdiadochokinesia. So remember that the cerebellum is really important in ensuring that we have smooth, controlled, coordinated movements. So this abnormality in rapidly alternating movements is a sign of cerebellar dysfunction. So what are other cerebellar findings on your neuro exam? You have your dysmetria, which is abnormal overshoot or undershoot whilst moving towards a target. So your finger to nose test, you would either overshoot or undershoot. You have your dysrhythmia, which is abnormal rhythm and timing of movement. So your heel to shin test on your neuro-OSCE would be abnormal. Truncal ataxia, which is a wide-based unsteady gait resembling that of a drunk person or a toddler. So that makes sense because you remember in patients who are chronic alcoholics, they typically have some level of cerebellar dysfunction. And in very young infants, their cerebellum is typically not yet fully myelinated. Scanning speech, you would have irregular fluctuations in rate and volume, again, sounding as if you're intoxicated. So those are some neuro-OSCE findings or neuro-PE findings which would point you towards a cerebellar lesion. Aside from digesting food, the gastric organ also has a neuroendocrine function. Which among the following is not produced in this organ? Is it ghrelin, pepsin, motilin, or serotonin? So the best answer here is letter C, motilin. So the gastric organ or the stomach does not produce motilin. Motilin, if we remember, is important for intestinal motility, as the name suggests, and it is produced in the M cells in your duodenum and your jejunum, not in the stomach. So things like your serotonin are produced by your enterochromaffin cells or Kulczycki cells in the gastric organ, and your chief cells, of course, secrete pepsin. Even ghrelin has also been found to be secreted by the stomach, although no specific gastric cell has yet been identified as the source for your ghrelin.
So question number 3, the coronary vessels receive blood flow during the diastolic phase of the cardiac cycle. What is the basis for this? Is it A, the sensibility, B, contractility, C, capacitance, or D, pressure? So our answer here is letter B, contractility. So what is the rationale for this? So remember that the coronary circulation is very unique in that it doesn't receive blood flow during systole, which is when the heart contracts. Instead, it receives blood flow during diastole or during the relaxation phase of the heart. The reason for this is there is mechanical compression and obstruction of your coronary arteries during systole, and it is only when the heart relaxes during diastole that they can fill up with blood and perfuse and supply oxygen to your myocardium. Now, I know this is not a straightforward question. However, it was based on a recall from the most recent PLE. So that mechanical obstruction and compression of the coronary arteries, what causes it? It is the contractility of the heart. And that is why the coronary circulation is unique in that it doesn't receive blood flow during systole, but instead during diastole.
Next question. Shear in cardiovascular physiology is described as lowest in areas where there is resistance, highest in the blood vessel wall, lowest in the blood vessel wall, or highest in the blood vessel center. So for shear, the answer is letter B. It is highest in the blood vessel wall. So what is shear? Shear is a consequence of the fact that blood within the blood vessel travels at different velocities. So at the wall of the blood vessel, the velocity is almost zero. And at the center of the vessel, the velocity is at its very highest. So you can imagine if you're inside the blood vessel and nasa gitna ka, it's almost like you're pulling the blood at the sides of the blood vessel. Therefore, there's a lot of pulling or shear stress on the arterial or the vessel wall. So shear is therefore highest at the wall due to the greatest difference in blood velocity between the center and the area closest to the vascular wall. Okay, and if shear is highest nearest the vascular wall, it is lowest naman at the center where blood velocity is constant. Sympathetic. So which of these are sympathetic? Is it A, glandular secretions, B, increased bowel movements, C, erection, or D, ejaculation? So the best answer here is letter D, ejaculation. So remember, parasympathetic versus sympathetic. Parasympathetic is rest and digest. So of course, glandular secretions and increased bowel movements, you can expect that in a patient who has parasympathetic activation. Sympathetic, fight or flight. Another way to remember the erection versus ejaculation is point and shoot. Erection is parasympathetic. Shoot, ejaculation is sympathetic. Next, Manuel went for his usual morning run in their subdivision. After 30 minutes of running, all of the following is expected to occur except A, decreased physiologic dead space, B, more pulmonary blood flow, C, equal perfusion from base to apex, or D, the oxygen hemoglobin dissociation curve shifts to the left. So except, the answer here is letter D. Okay, So it shouldn't shift to the left. You would expect it to shift to the right. Okay. So some things to remember during exercise. So first of all, your ventilatory rate increases. So of course, you're breathing faster, heavier because you're trying to meet the oxygen requirements of your muscles. Your arterial pH for most levels of exercise remains the same. However, if you're reaching your lactic threshold, meaning you're exerting in very strenuous exercise like sprinting or lifting very heavy weights for prolonged periods of time, you would eventually have a buildup of lactic acid, causing a slight decrease in your arterial pH. Your venous PCO2 increases. However, if I were to ask you, what about your arterial CO2 and O2 levels? Really important to remember, in a normal, healthy individual, your oxygen levels in your arteries and your carbon dioxide levels in your arteries should be the same. It shouldn't change. Pulmonary blood flow increases because your cardiac output increases due to sympathetic outflow, you're increasing contractility, you're increasing heart rate. Therefore, more blood also enters the pulmonary vasculature. Now, because more blood enters the pulmonary vasculature, you have a more even ventilation perfusion or VQ distribution. So remember that in a resting lung, usually perfusion is lowest at the apex, zone 1 or upper zone, and is highest at the basis or zone 3. Mostly because of gravity. However, if you are exercising, nagiging mas equal yung perfusion throughout the whole lung. Therefore, you have more areas of perfusion in the upper zone. So parang almost similar na yung ventilation perfusion ratio in the lower zone and in the upper zone during exercise. And it's because of this that we also decrease the physiologic dead space, because there are no longer alveolar sacs that are not being supplied with oxygen and are not participating in, alveolar sacs not supplied by blood and are therefore not participating in gas exchange. Because usually the physiologic dead space is concentrated in the area where perfusion is the lowest or the apices. So if you increase blood flow there, you decrease physiologic dead space. And of course, due to lactic acidosis during strenuous exercise, or even during exercise in general, the oxygen hemoglobin curve is expected to shift to the right. Remember, when you shift to the right, kabet, do the right thing and let go, your hemoglobin is more willing to give up oxygen. So, syempre, in a person who is exercising, the muscle is using a lot of oxygen. You need generous hemoglobin to supply the muscle with the oxygen it needs to meet its metabolic demand. Next question. The Ocean Gate Titanic expedition ended tragically when it imploded at a depth of 13,120 feet. Humans cannot withstand underwater pressure as it causes lung collapse. Which of the following is a maximum safe depth for diving below sea level? So the answer here, according to your guide on physiology, is 200 feet below sea level. So above that, it is no longer considered a maximum safe depth. So according to your guidance, at past 200 feet below sea level, that is no longer quote-unquote safe, though of course what's safe varies from person to person. Some other things under physiology that you need to know about diving: you have to be careful about rapid ascent because of the ability or the possibility of causing decompression sickness. Essentially, when you're in really deep, you have lots of pressure going around you. Increased pressure means there is increased solubility of your gas inside the blood. As you ascend, there is decreased solubility of the gas in the blood, and you start to form nitrogen bubbles. These nitrogen bubbles can then travel, and they can go to the vessel supplying your muscles and your joints, which would cause your bends because there's ischemia of your muscle and your joints. Or they can go to the blood vessel supplying your heart, your lungs, and your brain. So they can cause stroke-like symptoms or your chokes, manifesting usually as difficulty breathing. So again, the maximum safe depth, according to Guyton, is your 200 feet below sea level. Next question. Ta and T have been married for 5 years now and have been trying to get pregnant since. Ta wanted to know if he is impotent. What instructions will you give him prior to collecting the specimen for semen analysis? Does he have to be NPO for 8 to 10 hours, no sexual intercourse or masturbation for 5 days? Does he have to drink more water or to avoid eating foods high in protein? So our answer here is letter B. He has to abstain for 5 days. So according to your Henry's clinical diagnosis and management by laboratory methods, some instructions we need to give patients before semen analysis is: number 1, dapat for at least 2, at most 5 days prior to collection, there should be sexual abstinence. So this includes masturbation. Bladder should be evacuated prior to ejaculation, and the specimen should be delivered to the laboratory within 1 hour of collection, and it should be kept warm during transportation. So not iced, not refrigerated. Hidilyn Diaz won the country's first ever Olympic gold medal. She's earned a combined total of 224 kilograms weight lifted in the 55 kg women category during the 2020 Summer Olympics. She was able to lift that much weight because muscle strength is dependent on. Our answer here for the physiology exam, of course, in real life, it varies, is letter A, size. Because according to Guyton textbook of physiology, the greatest determinant of muscle strength is muscle size. Okay? Next question, which of the following organ systems has the most efficient regulatory mechanism? Is it the respiratory, cardiovascular, gastrointestinal, or neurologic? So our answer here is cardiovascular. So why is the cardiovascular system the most efficient in regulation? So that's because of the mechanisms in place for what we call autoregulation. So auto self, which is the regulation of blood flow by the tissue itself. The cardiovascular system is primarily responsible for maintaining a constant blood flow to all organs, including your neurological circulation, your renal circulation, and even its own circulation via the coronary arteries. So it is able to auto-regulate when you have too much blood flow or when you have too little. For example, when the brain has a buildup of carbon dioxide and a drop in pH, what responds? Diba? The cardiovascular system responds by vasodilating the cerebral arterioles. If there is hypoxia and a build of local metabolites like your adenosine in your myocardium, your coronary arterioles respond by vasodilating, thereby increasing the coronary blood flow. So things like parasympathetic and sympathetic innervation from your nervous system, yes, they still do play a role in autoregulation, but the cardiovascular system is really chiefly responsible because of its ability to increase and decrease pressure, vasoconstrict, and vasodilate very quickly and efficiently. So that is why, for this question, cardiovascular system is our answer. What will happen if GnRH is given in a continuous infusion instead of mimicking the normal pulsatile mechanism release of the brain? Will it inhibit FSH and LH, increase estrogen, increase progesterone, or stimulate FSH and LH release? So the answer here, we know also from pharmacology, I discussed this, is inhibition of FSH and LH. So remember that GnRH in a normal pro-fertility fashion is given in a pulsatile manner. Okay, so that mimics the usual physiologic way that GnRH is released by the brain. If you give it as a continuous infusion, you end up being anti-fertility or anti-physiologic. So the release of LH and FSH by the anterior pituitary is lost. Okay. Next, steroid hormones enter their target cells via facilitated diffusion, simple diffusion, primary active transport, or secondary active transport. So your steroid hormones, like your sex hormones, we know that they enter the cell via simple diffusion. And the reason they can enter the cell quite quickly via simple diffusion is because of their largely lipophilic nature. So they don't need receptors on the surface of the cells. They need receptors either in the cytosol or the nucleus of the cell because they can easily diffuse through the cell membrane. Next question. The largest area in the homunculus is represented by A, trunk, B, arms, C, brain, or D, finger and face. So the answer here is letter D, the finger and the face. So in the sensory homunculus, the largest areas are your fingers, your hands, and your face, and you need this for precise localization. So the face, the hands, and the fingers are really, really densely innervated by somatosensory nerves. So this makes sensitivity the greatest, and therefore it also has the largest corresponding area in your homunculus. Next, JC has recently been diagnosed with MG. The neurotransmitter affected in this autoimmune disease is produced in which nucleus in the brain? Is it substantia nigra, nucleus basalis of Maynard, locus coeruleus, or your Renshaw cells? Our answer here is nucleus basalis of Maynard. So ano nga ba yung neurotransmitter affected in myasthenia gravis? So we know it's the receptors affected for acetylcholine or your ACH. So remember, MG is an autoimmune disorder where there are autoantibodies against the ACH receptor. Now, ACH, let's go through the neurotransmitters and their nuclei in case lumabas. So ACH is produced by nucleus basalis of Maynard. Your dopamine is produced in the substantia nigra, which is why you have decreased substantia nigra in patients with Parkinson's. Norepinephrine, produced in the locus coeruleus. Serotonin, median raphe of the brainstem. But if they ask you where is serotonin produced the most, is it in the brain or in the gut? It's actually in the gut. Histamine in the brain produced by the tuberomammillary nucleus, and glycine is produced by your Renshaw cells. So Just a quick micro-correlate. What affects the Renshaw cells nga ulit, causing a decrease in glycine? Diba? It's your tetanus toxoid, or your tetanus toxin. Okay? Electrical impulses gather and accumulate in which part of the neuron in order to initiate an action potential? Is it the dendrites, nodes of Ranvier, axon terminal branches, or your axon hillock? The answer here is letter D, the axon hillock. So let's review the parts of the neuron. So number one, you have the soma, or your cell body. So this surrounds the nucleus and contains your organelles like your endoplasmic reticulum and your Golgi apparatus. Then you have your dendrites. Okay, so the dendrites are where the neurotransmitter receptors are found. So the tapering processes, which are your dendrites, receive information. So because they receive information, they have receptors. Then going down the cell body, you then have the axon hillock, which is this area here, para siyang neck. Now, the axon hillock is a specialized region, and next to it, we find what we call the spike initiation zone, which is where all action potentials are generated to send information. So as you generate action potentials here, it goes down what we call the axon and goes into the axon terminals. As it goes down the axon, some things it can do to speed up conduction is by skipping through the nodes of Ranvier. So the nodes of Ranvier are unmyelinated portions where action potentials are regenerated and they can skip through it, and it makes neurotransmission faster. At the very end is your axon terminal, which is away from the cell body, so it gives information, whereas your dendrites receive information. So since it gives information, this is where your neurotransmitters are usually contained. So dendrite receives information, soma, nucleus, axon hillock, action potential is generated, goes down the axon, goes to axon terminals, and it sends out the neurotransmitters. What is the earliest stage at which specific granulocyte types can be distinguished from one another? Is it your myelocyte, promyelocyte, metamyelocyte, or your myeloblast? So our answer here is letter A, your myelocyte. So the specific granule formations that would help you distinguish a neutrophil from an eosinophil or a basophil are said to start at the myelocytic stage. So let's just quickly remember the different stages from a stem cell eventually maturing into a mature white blood cell. So remember, we start with a multipotent hematopoietic stem cell. We then develop into your progenitors. It starts as your common myeloid progenitor until it becomes your granulocyte monocyte progenitor. It becomes a myeloblast, and then a promyelocyte, and then a myelocyte, and then a metamyelocyte. So just remember, whenever my blast, it means it's really immature, pro, before, meta, beyond. So myeloblast, super immature, promyelocyte, before myelocyte, myelocyte, and metamyelocyte, after myelocyte. Then you see your bands and then your segmented neutrophils, your eosinophils, or basophils, whichever the mature cell is. Okay, but at the point where you can start to distinguish the specific granule formations, that happens at the myelocytic stage. Number 17, what is the normal diameter of the adult red blood cell? Is it 6.5 micrometers? Is it 7.8 micrometers, 9 micrometers, or 5.5 micrometers? So our answer here is letter B, 7.8 micrometers. So unfortunately, sometimes you will be asked kind of these ridiculous questions na medyo hindi naman necessarily relevant to the practice of medicine, but they do sometimes come out in the boards. So it's best that we know them now during the midterm exam. So diameter, according to Guyton, is 7.8. Thickness is 2.5. We know that in the center, it is much thinner. So the central thickness is 1. And the average volume is 90 to 95 cubic micrometers per red blood cell. Okay. Next, you wake up late one morning, you opened your eyes and saw bright sunlight gracing your window. What happens as light enters your retina? Is there isomerization of transretinol, inhibition of phosphodiesterase, opening of sodium channels, or increased glutamate release? Our answer here is isomerization of transretinol. So, what happens at photoreception? So this is quite a complex topic, but it seems to always come out in the boards. So remember, in your retina, you have a substance called rhodopsin, which is your photosensitive pigment. It is made up of opsin and retinol. Okay, so rhodopsin is opsin and retinol. Now, when light enters your eyes and hits the retina, what happens first is there is photoisomerization So from 11 cis retinal, when light strikes, it becomes all transretinal. Okay? That then causes a series of conformational changes which culminates in the production of metarhodopsin 2. With metarhodopsin 2, it activates a G protein called transducin. Now, what does transducin do? It stimulates phosphodiesterase to convert cGMP to 5' cGMP. Therefore, you have decreased level of your normal cyclic GMP. Now, because you have decreased cGMP, your sodium channels, which are normally regulated by cGMP, become closed. Therefore, sodium cannot go in the cell and it is hyperpolarized. Because it is hyperpolarized, you don't secrete or excrete glutamate. However, what's weird, so hyperpolarization, decreased glutamate release. What's weird with the retina and with the visual system is there is a receptor after this called the metabotropic receptor, which if mababa ang glutamate, it actually causes depolarization to an action potential. So the visual system is unique in that sense. Okay, so remember, so let's look at the choices kanina. Inhibition of phosphodiesterase is wrong because we actually activate phosphodiesterase, which causes decreased cGMP, which causes closing, not opening of your sodium channels. And because your sodium channels are closed, you cannot depolarize. Therefore, you have decreased glutamate release. So all of the other options are incorrect. Next question, we have Innie's HbA1c result of 7.5%. The body normally produces a hormone to regulate this. What is the hormone's secondary messenger? Tyrosine kinase, CAMP, CGMP, or IP3? So the answer here, the best answer here is tyrosine kinase. So we know that the question is asking for a second messenger. So first, actually, let's figure out what hormone is it trying to pertain to. So yung HbA1c, diba, that is your measure of glycated hemoglobin. So that will let us know whether there is impaired glucose regulation commonly seen in diabetics. And of course, the hormone that we would look at is your insulin. Therefore, we would look at how does insulin act on a cell? What are the mechanisms of its action? So although the question asks for a secondary messenger, the best answer is tyrosine kinase because we know that insulin doesn't cause any increase in CAMP, IP3, etc. Instead, it uses the tyrosine kinase pathway. So ano nga ba yung tyrosine kinase pathway or mechanism? So remember, you have a receptor with intrinsic tyrosine kinase activity for your insulin. When insulin attaches to the receptor, what happens is the receptor phosphorylates itself. So it phosphorylates itself. It causes tyrosine to phosphorylate and other proteins as well. And then you have the downstream effects of your insulin. Okay, so just remember, tyrosine kinase is your insulin, your IGF-1, your growth hormone, and your prolactin. So insulin and IGF-1, madali i-remember kasi insulin sila both. Remember, IGF-1 is related to growth hormone din, so that will also help you remember growth hormone is via the tyrosine kinase mechanism. So for CGMP, dalawa lang yung kailangan yung i-remember. It's your ANP or your atrial natriuretic peptide and your nitric oxide. So if it's not insulin related, if it's not ANP or nitric oxide, it is either CAMP or IP3. And we know, of course, that your steroid hormones don't need a receptor because they are lipophilic. They can just diffuse through the cell membrane and attach to a receptor either in the cytosol or in the nucleus. See, thyroid hormone, it's not a steroid hormone, but it is so small that it can easily diffuse through the cell membrane. Okay? Next, astronauts in the International Space Station need years of training to enable their bodies to adapt to physiologic changes in space. The following are expected to happen in space except decreased bone mass, increased RBC, decreased muscle strength, or decreased RBC. So testmanship, dalawa lang yung exact opposites. Therefore, it's either B or D, so it gives you a 50-50 chance of getting this question correctly. So tip, whenever you see two options that are directly opposite of each other, it's either one or the other. Yun lang yung sagot. So 50-50, answer is increased RBC. So actually, chronic effects of adaptation to space include decreased blood volume, decreased red blood cell, decreased muscle strength, decreased maximum cardiac output, and decreased bone mass. Okay, so decreased lahat. All right, so that's it for your physiology.